Okay, today we will be discussing gait analysis in cerebral palsy because every step matters. Every step matters when I say because every step matters not only to the child or the patient, every step matters to the parents and the family members. This is something which excites any parent when they see their child taking the first step. So, but in cerebral palsy, unfortunately, the steps that child takes may not be normal or may not be up to the expectation of the family member. Now, and one important question is when uh, physiatrist or a rehabilitation should start in patients with cerebral palsy. The answer to this question is at the time of birth, as early as possible, because birth asphyxia is the most common cause for the cerebral palsy. And the moment patient has a birth asphyxia and he has complications because of the it, he may have it. When to do the gait analysis? Once the child starts walking or someone starts walking, what is the age for someone to stand? It is 6 to 8 months, and it starts walking at 1.5 years to 2 years. And mostly in patients with cerebral palsy, it is delayed, but it may not be delayed as well. So the important part is that we have to understand the milestones of development first for every cerebral palsy child, and then only you can decide about gait analysis. Then birth asphyxia is a common cause for cerebral palsy or hypoxic brain injury is there, and every hypoxic brain injury is not a cerebral palsy. We have to always remember it. Most of them may recover, as per Bradham, it is up to 50% of them by the age of 2 years. So 2 years would be a cutoff for the deciding about the cerebral palsy. So gait analysis becomes important. Why it becomes important? Because the rehabilitation decisions, medication decision for the cerebral palsy will depend mainly on the gait. And when I'm saying gait, and then you have to understand first thing is what type of cerebral palsy is there, where what is the cause for this cerebral palsy. And always remember that cerebral palsy is a UMN disease. Upper motor neuron brain is involved, but obviously it is UMN. So spasticity is the common thing that you will get. Flaccidity may come at some point of time, or some features of flaccid gait will be present. I'm not saying it won't be there, especially in initial 2 3 years of age. You will find that child may have a flaccidity, but all children will not have it. And this is spasticity you have to understand and you have to evaluate and analyze. So now there are two three things that we have to understand. The cerebral palsy, it can be because of hemiparesis or hemiplegic, or it can be because of the diplegia or paraparesis, you can call it diplegia when both the lower limb are involved. Hemiparesis only one side is involved. So the differentiation of the gait becomes important in these patients. First, hemiplegic or diplegic, what it is there, and if spasticity, which joint or which muscle is spastic, that is leading to that. And the most important thing in gait analysis and cerebral palsy is the ankle activities and ankle movement. Whenever we are doing gait analysis, two things that are important. It is one is the kinetics, another is the kinematics. Kinetics Kinematics mainly is the ground reaction force, how it is working, what are the joints, or what are the forces involved. So these things needs to be taken care of. But kinetics, it is the joint activities or what are the joint that is working on it, what are these, whether it is symmetrical, asymmetric, and all these things will decide about it. So kinematic part, which is the movement part, that is without considering the forces, that is the mostly we can analyze 2D or 3D or whatever. 2D through your mobile. If you have a gait analysis, EMG reading, and all these things will be very important. And kinetic analysis will be the force and all. For these, you need a proper gait lab. But The kinematic part is very important. Even you can do it with your mobile phone. Only thing is you have to take a front view video, a side view video, and a video from the back and make it into a slow movement. Slowly you will start realizing and reading it. I think in clinics you can do it in day to day, and EMG and all becomes very important. And the important part is the moment child enters into your OPD, you have to take into view multiple things. What are the things that you can see? What is the speed? What is the step length or stride length? How much is the single limb support? And all these things has to be careful. One important thing is hemiplegic, paradiplegic. I said another that is important is dystonic gait. In will dystonia gait analysis is really challenging in those children, and so it becomes important. So eye sees what mind knows. Whatever you know, same thing you will see. One important thing about gait analysis or gait assessment of any children is whatever deformity is seeing, it is in due course of time, and it is because of the compensation that has to be always taken care in the mind, not the primary pathology is there. And why we need a gait analysis to decide about the treatment plan. When I say treatment or management plan, it is not just few medicines, few surgeries. It includes injections, how much spasticity we have to preserve, and how much spasticity should be lost in the patient with our treatment, what orthosis to decide, and what is there. But most important thing that we have to keep in while analyzing the gait, doing the gait analysis, is the energy expenditure. All of us are lazy. Only thing is, all of us go for the energy saving mode. Whenever you are using your mobile and you have 15-20% of battery left, what you go is for the energy saving mode. Keep this thing in mind while doing any procedure, any management, any medication in the children with cerebral palsy, that you have to save the energy. If energy expenditure is already 2 to 3 times than a normal gait in the children with spastic sorry with cerebral palsy, irrespective of the type of gait. So keep this thing in mind. Always keep management plan. First thing you are writing, am I going to save his energy with my management plan? How will my step, my decision is going to save the prevent decrease the energy expenditure of the children? Because most of these children, suppose they have to go to school, and you are able to decrease the energy expenditure, then this will be definitely beneficial for them to roam around daily activities of daily living. Otherwise everything will be compromised, all day-to-day activity will be compromised. Once these things are compromised, children will have a lot of psychological issues and so on. So the gait analysis even has a role with psychological aspect for the activities of daily living and everything. So keep only one thing in mind: we have to go for energy expenditure in our prescription at any cost. Although we cannot bring it to normal energy expenditure, but yes, for with proper management, energy, whatever current energy expenditure of children is there, that can be brought down. So keep this thing in mind. So what are the gate deviations that is present? This is mainly from the Bradham. There are two references which I am using: Rhoda, which I have already shared in the WhatsApp group of Rehab Adda, and this one is the from the Bradham. This is taken from the Bradham. Scissoring gait. When the scissoring happens, scissoring is, that's all. Scissoring moving around. When the hip adductors to is tight or spastic. If the hip adductor is spastic, then the hip will go towards the adduction, and that will be responsible for the scissoring gait. So whatever, and the medial side of hamstring will be also spastic. That is very important. Now for scissoring gait, when to go for surgery? Adductor tenotomy, myotomy, hamstring lengthening, all these things can be planned, but when to go for it? When all conservative measure fail. Surgical intervention, please go only when all conservative measurements have failed. You have tried proper strengthening of the muscles, then only. Best way to handle uh, what I advise in the OPD for the patient with a scissoring gait For the with adductor spasticity or tightness, put the pillow between the thigh. That will work. Ask the family member to strengthen it, because I always believe mother is the best therapist, because children or kids are always comfortable in the lap of a mother. So always advise them how to abduct the hip in and keeping it stressed for at least 5 seconds, and then do it multiple times, and that can be done. Okay, so scissoring it, always make sure, because it is a not natural tendency. Okay, we at some point of time we get fed up, what to do, what not to do. Now, question is anti-spastic medication, whether it is needed or not needed. Anti-spastic medications, scissoring it, yes, it will benefit. What anti-spastic medication? Baclofen, yes, it can be given, but baclofen, well, you have to be careful about the history of the seizure, because baclofen is going to decrease the seizure threshold. Now comes the jump gait. In jump gait, this ankle is in equinus. That is an important thing that you have to remember. And if a ankle is in equinus, then there will be tightness of the gastrocnemius. That is an important thing. When I'm saying any gait, ankle becomes very important, or the gastrocnemius. Gastrocnemius is the most important muscle group for this impatient children with CP. So jump gait, hip and knee will be in flexion, and ankle will be in equinus. So jump gait is a type of equinus gait, or it is also called apparent equinus. True equinus, always remember, true equinus is in if gastrocnemius spasticity or tightness is there. So accordingly, you have to see, you will, if gastrocnemius spasticity is there, what will happen, that ankle will be in the plantar flexion. So most of the toe walking children will be there in the gastrocnemius. Crouch gait, again, everything for crouch gait to remember is everything will be in flexion. Ankle will be in dorsiflexion, knee will be in flexion, and hip will be in flexion. So child will be just bending down and then moving around. So when this ankle goes into dorsiflexion, be careful. Crouch gait, always remember, is the gait which can be, which is the has a maximum energy expenditure. So you have to manage things accordingly, so that my energy expenditure is minimized. So children with crouch gait, uh, hamstring, psoas, gastrocnemius, everything, all hip and hip, knee, and ankle contractures will be there, mainly hamstring and psoas and rectus femoris. So what to do for this hamstring stretching and all? Osteotomies will be needed at some point, with patellar tendon advancement will be needed. Stiff knee gait, knee becomes stiff, and in this stiff knee gait, mainly it is because of the rectus femoris will be overactive during the swing phase. Mostly all the gait which I have said, all these the four deviations: Caesar, jump, scissoring gait, jump gait, equinus, and crouch gait. It is mostly whatever you will find this thing. It will be the stance phase. This is stiffness. The stiff knee gait is mainly in the swing phase. So although these, I'm not saying that these four thing is only for the stance phase. It will have its effect in the swing phase as well. Child will be, for example, if it is equinus or jump equinus gait, child will be dragging its toe. That is possible. Scissoring gait, abduction will be there in the swing phase. So all these things will be there. That has to be always kept in mind. Now this is from the, again, from the Bradham. Now remember, it is for the spastic diplegia. I said spastic diplegia or spastic hemiplegia will be there. Spastic diplegia, true equinus. Always remember, true is only something that is related to the gastrocnemius. If gastrocnemius is tight, plantar flexion, plantar will go lower down. This will be more than 90 degree. This is what it is written, and this is all again taken from the Bradham. So what is the treatment for this true equinus? If in the stance phase, if child, what will happen in the true equinus gait, the loading response, or the initial contact will be not through the heel strike, won't be there. It will be through the mainly the toes. So that will be there. Jump gait again. There will be tightness of gastrocnemius will be there. It is a type of true equinus, you can call it. gastrocnemius is involved. But here, if you look, knee is in flexion, hip is in a little bit of flexion. So this is because in jump, child will be jumping from one, like a kangaroo will be jumping from one to other. Apparent equinus, it appears to be equinus, but it won't be an equinus. This will be almost 90 degree, that is neutral, but knee will be in flexion. It appears like apparent equinus. It is very common in the OPD. And the crouch gait, as I already told you, asymmetric gait will be always there. It will be jump gait, or apparent equinus will be there. So hemiplegia, raw foot, the foot will be more than 90 degree, and it will be because of the weakness of the one side. Knee and hip will be in will be at 0 degree, or you can call it in extension. There won't be much. So what will be the treatment for that raw foot? Only AFO, hinged AFO you can give. True equinus, as I already told you, it will be with the knee in the plantar flexion. That is an important thing. Once the knee is in plantar flexion, sorry, ankle is in plantar flexion, loading response will be, initial contact will be affected, loading response will be affected, and everything will be affected. So gastrosoleus and all. So everything has to be decided accordingly to equinus, or then jump knee gait will be more or less similar to that we will get in a, spastic diplegia. So the ankle, it becomes important. Only thing is, apparent equinus, this plantar tibia will fall forward because of the knee will, or just like ankle will may mimic that of a crouch gait ankle. So remember these things, and there are equinus or jump knee will be there, only knee will be affected, and if a hemiplegic there is there, then there will be circumduction gait will be there. So again, this is from the Rhoda. It is more or less same, which is there in the Bradham, and so this should be taken care of. So message to OPD: never treat a single joint in isolation. Always remember, you cannot treat one joint or one thing. You have to look into for gait abnormalities, and if you are planning any intervention, medication, or any interventions with an orthosis, prosthesis, any injections, or any muscle release, or rhizotomy also, or any surgical or muscle soft tissue release, always visualize what will happen to this condition. Why I'm saying this? Because this is an important, because see, there is a very common tendency people to go for hamstring release in children with apparent in jump gait. And what happens the moment children has this hamstring release slowly, and the TA release as well, the child will equinus gait, child will slowly go into the crouch gait in due course of time. So what always try, especially if you cannot make it normal, then the best thing is to try for equinus gait rather than the crouch gait. Energy consumption has to be saved. Now, how to manage the equinus gait? Best thing is to try series caster or plaster. It can be series casting, can be tried slowly. Slowly, you try to back it into neutral. Then, along with this, some medications can be tried. Tijanidine can be tried, centrally acting. Uh, Baclofen can be tried, and you have to be cautious. Muscle relaxants like benzodiazepine, long acting, can be tried. So go ahead with it. Then always have to distinguish between what is the cause for it. Whether this spasticity is dynamic when child is going for some activity, or some fixed contracture is there. So that has to be there in their mind, because at some point a spasticity always gets exaggerated. Is there some, if there is something that is triggering, and instrumented gait analysis, as I told you, 2D and 3D. If it is available, definitely go ahead with the kinetics, kinematics, and EMG of which is the gold standard. But observational gait analysis sort of things with the today's good quality mobile with Android phone, it can be done in our own OPD. And always remember, one more important thing is crouch gait is a progressive deformity. When I say progressive deformity, I mean that if you will see, observe a children who is walking at 3 or 4 years, by the time he reaches his teen, he or she reaches his teen, automatically this equinus changes into the crouch gait. So early intervention with hamstring release and TA release is never suggested until unless it is causing lot of issues or children lot of problem. Crouch gait is never advisable. Crouch gait is there. You have to be careful. Lot of the corrections of opposition will be there. And always, whenever you're planning for any treatment, always consider the entire kinetic chain. Video gait analysis now with lot of apps even are available through which you can do the video gate analysis. If there is any questions, because discussing this gate analysis, repeat gate, every gate will need one class. So hope you all had your good tea. If there is any question, please feel free to ask, and then we will see again next Friday, 6 p.m. with your cup of tea. Okay, and most probably next Friday we will be discussing about HO. Okay. Any question? No questions. Good. You all can join. I will just share the Rehab Adda link, WhatsApp link, which you can join in anytime or ask your friends to join and discuss whatever you wish to discuss. Okay, we can stop the recording.